Good afternoon, everyone, and welcome to today's really very special speaker in the Department of Epidemiology. So Teresa Janevic, who's currently Associate Professor in the Departments of Population Health Science and Policy and Obstetrics, Gynecology, and Reproductive Science at the Icahn School of Medicine at Mount Sinai downtown, is also a alumna of our PhD program. And while she was here, I had the real pleasure of working with her on several projects. And she is really a very fabulous epidemiologist. And I can think of no greater honor for me, as who was one of her supervisors here, to introduce her here as a speaker. And it's really, really very moving. So Dr. Janevic is a perinatal epidemiologist, and she studies social and structural determinants of maternal and infant health. She has a real passion for women's health equity that was nourished when she was at the University of Michigan as an undergraduate, where she studied social history. She obtained her MPH in epidemiology and biostatistics from the University of California, Berkeley, and her PhD from here, as I said. She received the Anna C. Gelman Award for Excellence in Epidemiology. She then went on to complete a postdoctoral fellow in global public health at Yale and did a lot of extensive work in the former Yugoslavia. She also was an assistant professor at epidemiology at Rutgers, where she redesigned the master's curriculum and expanded the maternal and child health curriculum. She's extremely well funded and has been funded by the March of Dimes, the World Bank, the Open Society Institute, CDC, HRSA, the Russell Page Foundation, and of course, NIH. And so her research really examines the intersection between social and structural exposures such as policy, racism, neighborhood context, immigration and stress, and the outcomes of maternal and infant health and the quality of healthcare. And today she's going to be speaking to us about some of her recent work on social and structural determinants of postpartum cardiometabolic health, which is an area of active research at NICHD. So please, thank you.
Thank you, Pam, for that fabulous and moving introduction. I'm excited to be here today and share with you what I've been up to. So first, I'm going to talk a little bit generally about my research program, and then I'm going to convince you why the maternal health crisis is one of the #1 public health crises we should be paying attention to, and why postpartum period is particularly important, and cardiometabolic health in particular is an understudied but really important area in that period. And then I'm going to talk a little bit about what are social and structural determinants, and give some examples from my current research. So most of the data I'm presenting you today is kind of in the process of being published. So please don't cite anything today, but I thought it'd be a little more exciting to have hot off the press findings. And finally, I'll talk about some future directions. So as Pam said, I'm a perinatal and social epidemiologist, but I also work in the worlds of health services epidemiology, but always with an eye to applied public health. So I've always established collaborations with the health department, for example, the New Jersey State Health Department when I was at Rutgers, and now I happily collaborate with the New York City Department of Health. And in the blue boxes, you can see some of the areas in which I study. So I'm a little unique in that I really enjoy mixed methods as an epidemiologist, and I also the typical prospective and retrospective cohort studies. And also, as many epidemiologists are turning to, I've also for the past 5 or 6 years been using quasi-experimental designs, borrowed in part from econometrics. And data sources I use are both secondary and primary collected data. And I selected examples from my research today to reflect the big secondary data analysis and then more of a nitty-gritty primary data collection analysis. So just a bit about myself to help you understand the lens through which I view this research, and how that might influence the questions I ask, to encourage you to question the question, as Aaron Bua said influentially. And this is kind of part of an anti-racism research approach that I'm only beginning to try to really engage with. And you can see here that I'm a white cisgender woman from working class Detroit with a lens from social justice. And I really kind of got into health because my mother was a nurse in Detroit. And this is something that's really influenced me when I was then at University of Michigan. I got turned on by everything I learned there that had been miseducated about prior to then. And that's really, since that day, I've kind of done this. I've studied social determinants of health. And I just think I have, when I teach about how to do a positionality statement to students or in workshops, I suggest sometimes doing a word cloud, because I think it's really difficult to do a positionality statement. And I find it's one way, first of all, the process of just putting all the words in helps you kind of brainstorm, think, oh yeah, that really does, you know, I'm a numbers geek, so am I just doing this because I love the method, or is it an important question? So it really helps you think about your biases, but it's also a little bit easier when you're starting out. So now to shift to the main topic for today, or the main impetus for my topic, which is the maternal health crisis that we're facing in the US. So many of you may be aware that the US has a deplorable maternal mortality rate, which is worse than all high-income countries, and all racial ethnic groups have a higher maternal mortality rate than other high-income countries. But the worst and most deplorable rates are among Black women. So unfortunately, the COVID-19 pandemic has made this worse. So these are all the most recent data about maternal mortality in the US. And on the left, you can see the purple bars. The light purple bar represents deaths not related to COVID-19. And then the darker purple bar, deaths related to COVID-19. So you can see that's really driven this rise in maternal mortality. And on the right is new data released about the increase in disparities resulting from the increase in maternal mortality rate. So unfortunately, we're going in the wrong direction. So what is the fourth trimester? Well, one reason that I focus on the postpartum period is it actually turns out that a lot of pregnancy-related death happens after that initial 6-day postpartum period. And what this graphic shows you is the distribution of deaths kind of after delivery, which is over half. And another graphic that everyone who's in EP1 has learned, but that's been taken up by the maternal health world, is the iceberg phenomena. And in the maternal health world, what the iceberg phenomena means is that we study maternal morbidity as the tip of the iceberg, or maternal like severe morbidity and mortality. But underneath that, you can see that it's a looming crisis of maternal health that we're not necessarily recognizing even by these disparities in maternal mortality. So I love this article from the UK where they actually put their data in the iceberg format, which I thought was super cool. And you can see that they show rates for hypertensive related morbidity and mortality from the tip of the iceberg, which is mortality, all the way down to the population level. But what I would argue is what this talk is going to be a little bit more about is what's under the iceberg is not only these obstetric outcomes, which yes, are super important, but it's also maternal health in general. And it's the fact that this is a critical period that we're just missing an opportunity to do something about. So I can't mention maternal health without mentioning Alan Rosenfield, who this building is named after, who wrote a very influential piece called subtitled, Where is the M in MCH? And then Dr. Dalton from here at Columbia have kind of brought that back in another very influential article, which has been about 10 years now, Where is the M in Maternal Fetal Medicine? But this has been now sort of a resounding chorus of we have to pay attention to moms as well. And I think this is really important for life course epidemiology as well. And I think it's because this is a life course model from a fairly recent one from the Journal of American College of Cardiology. And it shows, it's great. It shows sort of the multiple dimensions of life course and cardiovascular disease. But you notice it's focused around pregnancy is because it's focusing on the infant, right? So life course health we think of mostly is about what happens when you're a fetus and how that influences later development. But what's overlooked is that pregnancy is also very important in the life course for the mother. And so there's a profound physiologic and psychosocial transition that happens in the postpartum period. And I would argue that this is where the weathering, which is a term that was introduced by Geronimus and has been very influential in thinking about the deterioration. In particular, the term was first coined regarding the health of Black women, but since it's been other non-white groups as well, of how over the course of time, aging is accelerated due to the stress of racism. So I would argue that this postpartum period for the mom is really an opportunity where weathering is happening. So just a little bit about cardiometabolic health to set you up for the research I'm going to present. So there's two big pregnancy outcomes that are related to cardiometabolic health that we study a lot. One is gestational diabetes, and the other is hypertensive disorders of pregnancy. They're the most common ones. And gestational diabetes affects about 8% of pregnancies. In New York City, it's a bit more. And 14% hypertension, about 14% of pregnancies. And these complications often resolve in the postpartum period and are forgotten about. But actually, they're a warning signal that you're at increased risk across the life course of poor cardiometabolic outcomes. For example, if you've had gestational diabetes, there's a 20% risk of type 2 diabetes at 10 years postpartum. And both gestational diabetes and hypertensive disorders of pregnancy are associated with a twofold risk of cardiovascular mortality long term. So these are a cluster of conditions postpartum that really have a large impact on life course health. So I'm going to shift a little to the first part of my title, which is social and structural determinants of health, and talk a little bit, set up my concepts for you. So this slide I actually stole from one of my lectures of about 10 years ago that I used to give on what are social determinants of health. And this quote you may recognize from a pretty famous World Health Organization report that was landmark on the social determinants of health. And when you read the description, well, that includes things that we would consider structural things, right? The conditions in which people are born, the distribution of power, money, and resources. Well, that's structural. So I'll admit, for me, it took me a little bit of time to understand why we need to say social and structural determinants of health, because I thought, oh, well, it's in the definition of social determinants of health. But that's probably also just having heard social epidemiology for so many years, it's my resistance to change. So why should we say social and structural determinants of health? Well, this article by Dr. Pierre Perry was influential in changing my mind, because she argues that when we just use social determinants of health, the term has lost meaning within systems of care in particular, because of misuse and lack of context. And large social gradients in health and clinical outcomes persist. So in other words, we have to call attention to it, or it just becomes lost as social risk. And also, she argues that structural determinants of health, cultural norms, policies, institutions, and practices that define the distribution or maldistribution of social determinants of health are actually imperative. which actually reminds me a little bit of the famous quote from Bruce Link here at Columbia, "What puts you at risk of being at risk?" So I also want to just lay out some other concepts I'll be talking about today. So I'll be talking about Hispanic ethnicity, and I just wanted to state that when I talk about ethnicity, I'm thinking about it in two ways. And one could be considered attributional dimension, which is shared cultural and other characteristics. But there's also a relational dimension, and this is characteristics of the relationship between that defined group and the society in which it's situated. So this is going to, I'll be talking about Hispanic and South Asian and East Central Asian. I'm going to kind of gloss over them because I have a long talk, but this is really where the root of what I mean by using those terms. And race, I'm viewing as a social construct that's linked to phenotype or ancestry, but it indexes one's location in the social hierarchy. And the racism as the structuring of opportunity and assigning of value based on how we look. And I'll be talking later about different levels of racism, which I'll mention again later. And finally, importantly, I'm going to say women and occasionally birthing person throughout this lecture. And I just want to make it clear that I want to be inclusive of all pregnancy-capable genders in this research. Much of the data I'm presenting here is about persons who identify as women in the case of the primary collected data, and the administrative data that we don't actually know have gender information. But you'll hear me kind of use varying terms throughout the presentation. So this is the ecosocial framework for postpartum cardiometabolic health that's going to guide the research I'll present for you today. And I'm not going to read every word on this slide, but you can see that neighborhood, community, individual, as well as biological mechanisms I see as nested within structural racism, economic inequality, and gender inequality. And I'm interested in studying from policy, from the structures that policy working down, but also at the very bottom, the experience from birth, then across the life course and the lived experience of postpartum people. So just to kind of point out a few of the things more generally I study using this model, and then I'll mention the ones I'm studying, showing you today. So I have a body of research looking at Medicaid policy and how it influences some of these outcomes, racism, and also migration and a focus on immigrants. I'm also very interested in how these factors intersect with the quality of care, including access to care such as readmission rates. And then finally, two of the cardiometabolic factors I'm talking about today and I see as a part of the embodiment process are hemoglobin A1C and blood pressure. The first example from my research I'm sharing investigates racial ethnic disparities in type 2 diabetes after gestational diabetes. And this is from a study called the Apple Cohort. Now, the Apple Cohort has been a long-term passion of mine to get off the ground. So I'm very excited to share some of the first findings from it. It stands for A1C in pregnancy and postpartum linkage for equity, and is a collaboration with the New York City Department of Health and Mental Hygiene. And they linked for us, so we worked together on this, the hemoglobin A1C registry in New York City, which has every hemoglobin A1C test, New York City birth certificate data, and Sparks hospital discharge data. These are our current years in our cohort, but we're also in the process of adding more years. And the overarching goal of this is really to understand and intervene on these social structural influences on the path from gestational diabetes to type 2 diabetes. Much of the work in this area, despite being so sensitive to social and structural determinants, has really been on individual risk. So the research question we're going to explore a bit now, of many research questions from this cohort, is first, what are the magnitude of racial ethnic disparities in type 2 diabetes after gestational diabetes? And before you say, oh, it's another descriptive epidemiology study, it's actually part of the integral part of defining this cohort and kind of the proof of concept that it works. And so then we're going to go from there. And then we look a bit at to what extent social and structural determinants of pregnancy mediate these disparities. And finally, does this importance vary by race, ethnicity? So just to tell you a little bit how we came up with the gestational diabetes cohort from these linked data. So we looked at A1C, we excluded A1C levels that were 6.5% or greater during the first trimester. So they might have already had incident type 2 diabetes. And we also are able, from the birth certificate and the hospital data, to look at a diagnosis for type 2 diabetes at birth and exclude those persons. And then we included anyone that had a gestational diabetes diagnosis. And we have a pretty robust way to do that because we're able to look at if it was indicated on either the birth certificate or the hospital discharge record, which extensive research has shown has good sensitivity and excellent specificity. And then they formed the basis of our cohort. So in this particular analysis, 2009 to 2011 cases are our baseline, and we're going to follow them up over time. And so the first analyses that I'm showing you here, we're looking at what we consider diagnosed type 2 diabetes, which is the ADA definition using A1C, which is 2 or more hemoglobin A1C measures, 6.5% or greater after 12 weeks postpartum, when the physiology of pregnancy has mostly resolved. Race ethnicity was obtained from the birth certificate, where it's self-reported. And then you can see listed the social and structural determinants that we have available at this time, which include factors such as WIC participation, timely prenatal care, and then many clinical characteristics of their pregnancy. So to calculate the cumulative incidence of type 2 diabetes, we used Kaplan-Meier survival analysis, and then we tested for difference between the groups. And then we used Cox proportional hazards to estimate the hazard of type 2 diabetes by race ethnicity. We also conducted a mediation analysis to look at contributing factors, how much social and structural determinants and the clinical factors explained of the disparities. And to do that, we used inverse odds weighting to estimate the percent contribution. And this is appropriate for these data because we wanted to look at more than one. It's able to handle more than one mediator at a time. It's also, it can be accommodated with our survival model. And it's also a robust interaction between the exposure and the mediator, which I'll show you in a minute we do have. However, I want to pause here for a second and mention that I realize this is a very controversial type of analysis. There's a large debate in epidemiology if race, which is essentially what I'm using as my exposure when looking at hazard ratios by race ethnicity, if it can even be an exposure and if it should even be decomposed. And so I would, the argument I think for doing this analysis is that we're using race as a proxy for social experience in this cohort. I also would stress that I wouldn't consider this a causal mediation analysis. I look at it as a way to understand and describe the magnitude of the problem that we're going to dig deeper into and how to address. And I guess I draw also on the work from Vanderweel and Robinson, where they call it, okay, well, it's not exactly a causal analysis, but you can think about it as sort of an mediated inequality effect as a descriptive analysis. So it's with those caveats I present the following data. I guess the second footnote on that is, for those reasons, is also why I look at effect modification. So does the association between these social, structural, and clinical factors and type 2 diabetes vary by race ethnicity? And there's actually a great colleague of mine at Mount Sinai, Emma Ben, who every seminar stands up and says, what you actually should be doing is looking at what are the what's the distribution of exposure in these particular groups so that you can be creating and targeting interventions. And I actually do see the value in that as well. And it also can stimulate hypotheses. So I test for effect modification and present stratified data as well. So this slide is really just to kind of show off how much data we have. This is overall in the cohort, those with gestational diabetes, which the orange line is who I'm going to show you the analysis on, and those who do not have gestational diabetes, which is the blue line. So it shows, as you'd expect, the mean A1C levels increase over the years postpartum in persons with gestational diabetes, and not so much in those without gestational diabetes. Here are the survival estimates for 8-year cumulative incidence of type 2 diabetes. And the colored lines are the different racial ethnic groups. And the overall 8-year cumulative incidence of type 2 diabetes was 8.2%. And by looking at the fact that the highest two lines had the highest, the sort of poorest survival, you can see that, the best survival, you can see that East Asians and non-Hispanic whites kind of had the lowest cumulative incidence, and the light blue line is actually non-Hispanic Black persons, closely followed by South and Southeast Asian persons. Okay, the next step was to put this into a Cox model and look at hazards ratios. And so here you're looking at the hazard ratio. So that shows, for example, that Black women had a four times hazard of type 2 diabetes after gestational diabetes relative to non-Hispanic white women. And one reason this is actually in the perinatal world kind of a big deal is because it's kind of thought that disparities in gestation, like Black women don't necessarily, gestational diabetes isn't a big problem, but it kind of shows that there's a slight increased risk in pregnancy, but it shows it's really just kind of part of a life course story, and it kind of reveals the importance of cardiometabolic health in each of these groups. And then on the right-hand columns, you're looking at the percent. Those are percentages, no longer hazard ratios, of the disparity in the 95% confidence interval explained by each of those groups of mediators. So first the social structural, then the clinical, and then both of them combined. Oops, sorry. So what we found is that, what we have measured in these data really only explains about a quarter of the disparity between Black and white women, a bit more between Hispanic and white, and very little between South Asian and white women. So the next part of the analysis I promised was to then instead say, okay, I don't love the decomposition analysis. Let's actually look how each of these factors differ within groups and where the interactions are, where there are differences. So the factors you're looking at on the left are the ones for which there was significant interaction between race, ethnicity, and each of these factors on the risk of the hazard of type 2 diabetes. And so it's really interesting because actually, these things that we measure commonly, turns out they're more salient among non-Hispanic white women, and that they're not really explaining much of the type 2 diabetes in some of these other groups. So I think it is also a fascinating way to look at it. And also the BMI, the difference of the influence of BMI differs. That's a continuous variable, which is also a whole other body of research, which is really fascinating. But of course, what I'm mostly talking about today are these social structural factors, which simply differ in each group, in their impact. So you might be thinking, okay, she put together all these data in New York City. She's following them for over 10 years. Your brain might be kind of clicking and thinking, well, what about people who move out of New York City? Is this really a valid cohort? What's going on? So we did a lot of work to try to show the validity of this cohort. And this kind of a lot of thinking about this, but this kind of, I like to think of it as these types of biases that could be taking place. And I'll just pause for a second to say this actually could happen in most administrative data linkages over time, and does certainly with health insurance churn. It's probably worse than population-based data like we have, or within a healthcare system. But that said, I do think it's really important to consider. So one possibility is diagnostic bias. So it's possible we only have A1C tests. We don't have any kind of OGTT tests. So it is possible that some persons could have had OGTT tests, and they did have type 2 diabetes, so we missed them, but they just never got an A1C test. And if this was differential by whatever exposure we're looking at, in this case, race, ethnicity, it could bias our rate ratios. Another probably even more likely thing that's happening is that they moved out. Well, I'll start with the bottom one first. That's actually the most likely, that they moved out of New York City. We do know people move out of New York City after they have kids. Although it's kind of interesting because the data are shifting about how that's influenced by race, ethnicity. Like it used to be that white women moved out more with their families, but the most recent data is that's not true. So that's actually hard to even know how to make assumptions based on if it's differential by your exposure. It's also possible, and I'm moving backwards up my list, it's also possible that some women never received any type of screening. They're basically lost to follow-up at pregnancy. They live in New York City, they just never got an A1C test or any sort of screening. And then it's also possible that you had type 2 diabetes. It's not that you controlled it like in the diagnostic bias, but that you just never got an A1C test. You never could bother to try to control it. So you're not in our data. So all those scenarios could be happening. So what we did is we applied probabilistic bias analysis, which is basically allows you to look at a distribution of plausible values of these types of biases and how that would impact your results. And so to do that, you have to make some assumptions about what your in this case negative predictive value is, because we're pretty sure that we caught most of our problem is missing cases, right? So we varied our negative predictive value, and we investigated possible both screening bias and differential loss to follow-up bias, following that slide what I showed you just now. And the estimates in orange show you that the very top row shows you what I just showed you, our hazard ratios. And then in orange, it shows you adjusting for these biases. So you can see that all of these scenarios and the confidence interval shows you the range of plausible values. There is definitely still a significant disparity, although part of what we report in the overall hazard ratio could be due to some of these biases. Second way to look at it is, instead of the fancy bias analysis, we can only include people in our analyses if they ever had an A1C test. So I call this the A1C follow-up cohort. And this is actually pretty exciting. This shows you the percent of people who have an A1C measure of those with gestational diabetes, and it's really high. Orange is the percentage that show up in our data, and the blue is the percentage that show up in our data. So the alternative approach was to only use the blue people. And when we do that, we also have attenuated hazard ratios, which are kind of actually similar to the ones from the probabilistic bias analysis, but maybe slightly larger in magnitude. So often now, the different analyses we're doing with these data, we're including some of these sensitivity analyses to just really be upfront about plausible biases. So the conclusions thus far are that, yes, we do see these sizable population level racial ethnic disparities and progression to type 2 diabetes. And there's a lot of interesting paradoxes to be explored further. One, which I mentioned earlier, which is it kind of calls attention to this is an important health problem for Black maternal health. And also, the characteristics we had measured explained only a modest proportion of the disparities, suggesting richer ideologic research is needed, which brings us to our next steps. So I'm excited that I just have funded the next steps. So we're just now launching the next part of this study. And so the next part of the study, now that we've sort of done the proof of concept, is to do a mixed method study. And the goal is really how to change those trajectories we just looked at. And how can we do it using policy levers? So the first thing we're going to do is look at a broader, richer array of built and social environment factors and these trajectories from gestational diabetes to type 2 diabetes. I'll just mention we also look at it in more sophisticated ways, and I showed you just cumulative incidence, but we're also looking at Markov models to look at progression, say to pre-diabetes to diabetes. We're also looking at latent growth models to look at different trajectories. So there's lots of cool things you can do with A1C data. And then in parallel, we're doing a qualitative study. And we're doing with a sociologist, that's a colleague who really loves this method and sold me on it, a patient journey mapping, where we can kind of pair our map of their experience with the time of our cohort to look at different interactions, both with their social and built environment and also healthcare in the journey from gestational diabetes to type 2 diabetes to inform our quantitative analyses. And then finally, we're going to use all of that information and simulate what might possibly disrupt these transitions using agent-based modeling. So I'm super excited about that. So now I'm going to shift gears a bit and talk about, go from big data to much smaller data and talk about the VIBE study, which is a postpartum cohort study in Queens. But just to take a step back for a minute, how I started some of my early roots of studying racism and maternal health is in my postdoc at Yale in global health. I actually learned some qualitative methods, and I'm a big proponent of epidemiologists knowing at least some qualitative research, and of course partnering with social scientists as well. And this was a framework I developed using focus group data and adapting Dr. Kimara Jones's levels of racism framework to racism and access to maternal health care among Roma in Southeastern Europe. And so I ended up continuing to study this. I did a qualitative study at Mount Sinai as well. And then we arrived at the COVID-19 pandemic. And so, like many people, we were concerned that the pandemic would sort of exacerbate these existing deplorable structures of inequality that we see. And so we launched a postpartum survey in which indeed we found that women during the pandemic had terrible experiences of healthcare, and women of color had high perceived racism in the healthcare setting. And this was associated with postpartum anxiety and other mental health measures. So now we applied to one of the COVID-19 competitive revision supplements to study this in more detail and prospectively, and also for outcomes that are very, as I've argued today, extremely important to maternal health overall, and including the research I'll focus on today focuses on blood pressure. So the question overall is to understand the influence of racism and the COVID-19 pandemic together. And on the right, you can see again, there's those multiple levels of racism embedded within the pandemic, influencing postpartum maternal health. So it's a multi-center study at Penn and also at two affiliates of Mount Sinai Health, two New York City Health and Hospital affiliates of Mount Sinai in Queens. And we prospectively enrolled women last year from April to October and followed them for 3 months. And we included persons who identified as Black, Hispanic, or Asian and spoke English or Spanish. And you also had to have a working cell phone. And the reason you had to have a working cell phone is because we did a baseline survey in the postpartum unit. And then they went home with a postpartum text-based blood pressure monitoring system. It's called Way to Health. So they took home a blood pressure monitor and sent in their blood pressure readings for over 3 months period. And then we did a final survey. So these are some of the newest data from that study, which we're just now beginning to publish. And along with the design of the study, we formed a community working group. And the community working group consists of doulas, community health workers, educators, and reproductive justice advocates. And they were instrumental in the measures we chose in our survey, as well as interpreting the results and disseminating them once we are at that point. And the framework of the community working group is to hold the research team accountable to maintaining anti-racism and birth equity lens in this research. And this is that's our little logo on the right. So I presented 2 weeks ago at the NIH workshop for this Improve initiative, which is one of the maternal health initiatives. These preliminary findings. So what I'm going to present now are these preliminary findings on one of the particular exposures we looked at, which was gendered racial microaggressions. And I'm going to look at associations with gendered racial microaggressions and postpartum blood pressure, and then look at if COVID-19 economic stress magnifies these associations. So this scale is actually the first time it's been used in an obstetrics setting. And the community working group worked on adapting the items and made some changes to the items so they would be relevant to the birthing experience and also to their lived experiences. So we did tweak it slightly. And because we tweaked it slightly, we did a psychometric analysis, which we'll be publishing as well. And so just in brief, very briefly, we did some item response theory to show that there is one latent construct. So yes, we're measuring kind of one thing with the scale. And then what a lot of you might be thinking about is does this work in all the people that you recruited? And we did look at differential item functioning for Black and Hispanic persons and showed that it performed similarly in these groups. We used linear mixed models with repeated measures, because remember, we have blood pressure measures over 3 months, so we have a lot of blood pressure measures, and to look at these associations. I won't go into details about the model, but you can always ask if you're interested. And then we did look at effect modification between high and low risk. High risk meaning you had any hypertensive disorder of pregnancy, and also effect modification by COVID-19 economic stress. So this is our study population. You can see in the New York City Health and Hospitals is predominantly Hispanic, and at Penn predominantly Black. About a third of participants reported experiencing at least one gendered racial microaggression during their pregnancy or delivery care. And some of the most common items were feeling unheard, comments being ignored, or being told to calm down. And a little over a quarter of the sample reported high economic stress. So these are the results of the linear mixed model. You can see that there was an association between of 2 millimeters of mercury increase among those who experienced gendered racial microaggressions compared to those who did not. So 2 millimeters of mercury of systolic and 1.4 of diastolic. There was not an association with COVID economic stress. However, we did find pretty significant effect modification by high risk status. And I love this slide because it's perfect for a teaching slide and effect measure modification. So what you're looking at is on the right are the high risk persons, and you can see that overall, they have higher, this is for systolic blood pressure, they have higher intercepts, so they have high systolic blood pressure, but they also have a greater difference, which is really apparent in this picture, than on the left, which is low risk women, where you see this trend in the same direction, but not nearly at the same magnitude. So in conclusion, we did find that gendered racial microaggressions are common among non-white women at these Queens and Philadelphia hospitals, and it was associated with higher postpartum systolic and diastolic blood pressure, primarily among high-risk patients. And the COVID economic stress we've looked at thus far wasn't associated with this outcome, although that's not to say it might not be toxic to other postpartum health outcomes. So we're still working on these data. We've also applied for pilot funding. We want to follow these women up We'd like to know their blood pressure at 1 year, as well as tests, sending them a HbA1c card to see if we can, because I'm excited to collect data that way. And then a really important part we've learned is that the follow-up for women who had gestational diabetes or hypertension was terrible in these both of these clinic populations. So we're also interested in learning more about how they got lost to care and about their transition to primary care. I just wanted to mention briefly some of the other research that's very important to me. So one is what's called the Poem for Equity study. That's postpartum outcomes after expansion of Medicaid. So I have a study funded by the Robert Wood Johnson Foundation, where we're looking at postpartum utilization and outcomes as part of the Family First Coronavirus Response Act. There was continuous enrollment of Medicaid. So it was sort of a natural experiment where everyone got health insurance postpartum. And of course, the part I'm most interested in are, did this help with this transition for care for these people with gestational diabetes and hypertension? Because that's been one of the actual main interventions proposed about the maternal health crisis. And we also have a pending funding from the NIH to look at that now when the public health emergency is over, and we're shifting to a new landscape where some states have expanded postpartum Medicaid and some have not. I'm also involved in a study targeting postpartum mothers at highest risk. I'm a site PI to look at a prediction model where we're using machine learning to try to identify from the birth hospitalization who is at risk for readmission or emergency department use, and then to use that as a clinical risk score in an intervention. I'm also investigator of the Generation C study, which is a birth cohort we started at Mount Sinai. And I have some ongoing work in that cohort about structural racism, inflammation, and I'm hoping eventually to follow. Currently, we're following the infants, but I'd like to follow the moms and look at later cardiometabolic outcomes. And finally, the work in particular in Queens is intimately tied with a close collaborator who has a community doula program intervention. And I'm the evaluator for these interventions, and we just launched, we received funding to adapt the intervention for persons who have housing insecurity or shelter during pregnancy or justice involved women at Rikers. So that's another exciting area I work in. So just a few takeaways from my talk today. I hope I convinced you that postpartum period is a critical period for life course health equity for maternal health, and that social and structural determinants play a vital role. And finally, I think I've showed evidence pointing towards race and racism influence hemoglobin A1C and blood pressure, and that may reveal part of the process of embodiment and weathering that takes place in this critical postpartum period. I just wanted to thank my team, my central team, as well as my other team members and collaborators, as well as my funding sources. And thank you. I look forward to any questions. Yes, from Dr. Laracarina, please don't use the term non-white. My identity is not determined as the negative of another's. Please refer correctable to positive identification by BIPOC. Other descriptions, this will evolve, but with the involvement of those being studied. Yes, thank you for the comment. I will take that to heart. Yes.
Thanks, Teresa. It was a great talk. And it's a really impressive and really important body of work that you've been doing. One of the things that I really appreciated as a social epidemiologist is how much your work unlike much of the traditions upon which you're building in social epi, is bringing healthcare into the fold rather than, pushing away from it and focusing a lens of attention on to upstream, social and structural factors outside of the healthcare sector. And I wondered if, so I think that's a real strength of this, because I think that there's an inevitability of bringing in healthcare to the particular outcomes you're studying, right? Like with other outcomes, our ambition with primary prevention is that it prevents healthcare utilization needs, right? And here, there's just something that's obviously quite inevitable about interacting with the healthcare system, given the outcomes that you're focusing on. So I think that's really strong. I'd be interested in any thoughts you have about other domains of work where we need to have more of a sort of dual attention to the interactions between what's going on within the healthcare setting and outside. And then I have one more specific question, which is, given the importance of healthcare utilization to address these outcomes, and particularly the disparities in them, is your work also able to try to tackle how things like gendered microaggressions in a healthcare setting are actually acting as a deterrent to healthcare seeking, to healthcare utilization? In other words, turning people away from it to avoid it because they're anticipating it to such a significant degree based on their lived experience.
Thanks. Yeah, so I guess I'll answer the second question first, and then go to the first part. So I think that that's where qualitative research has been so enlightening, because I think that's definitely been shown in the case of maternal health care, that experiences of feeling you won't be listened to, a feeling that, as I said, you'll be told to calm down, or that your opinion of your own body isn't valid, definitely, not only going to healthcare, but maybe advocating for yourself in the healthcare setting. So I think we're also just beginning to think about how that influences quantitative analysis, and definitely should be thought about. And then in the first question, yeah, I feel like it's fascinating, because having originally been more rooted in neighborhood health paradigm and kind of moving over to healthcare, I was always thinking, when I was working on a study of looking at New York City hospital quality and severe maternal morbidity, it was so obvious to me that the hospitals with the worst quality were in the neighborhoods where all of the other bad outcomes that we've been studying with neighborhoods and health happen. So it's as if you can't look at one without looking at the other. So I just tried to tease that apart a little bit. I, in a paper, looked at how the neighborhood that a hospital is located at influences quality, and there was a contribution above and beyond patient case mix, or the patient's residence, for the hospital neighborhood. So I think it is part of the story of structural racism, and how resources are shaped, and probably how interactions are even shaped within that hospital, because it's a context, and that context is existing in another context, which is the neighborhood. Yeah.
Right. It's Laura. Dr. Ezra Susser has a question from the chat.
Yeah, hi. I very much liked your talk also. And since you like qualitative data, which I do too, I was wondering if you had considered or had used photo voice, because it gives you, it's based on originally the ideas of Paulo Freire, and as well as on feminist work. And it really gives you a deeper understanding of, in people's own voices, of how they experience a situation such as pregnancy and hospital care, and what they think are what they develop as the potential solutions. Yeah, you're probably familiar with it. I'm not quite sure, but.
Yes, I am a little bit. I mean, that's a fantastic idea. I've thought a little bit about that, and haven't actually made that dream come to life. But I totally agree, especially within a healthcare system. I even thought of it as part of patient experience sort of apparatus we have at the healthcare system. I thought about we should have something like that. That's where it's something also that med students could be involved in. So it's one of those things that's been rattling around. But I appreciate that because I would love to, if you have any ideas about how to incorporate it, I would love to.
But that was great. I really enjoyed the progression, the study progression, and to see your career progression. I was also interested just to see your use of Way to Health, actually, which I thought was really neat. And the relatively new medical center director here, Katrina Armstrong, was one of the people who actually put that into place. I think it's got to be about 15 years. It's quite some time. So super to see that. So my question is about the VIBE study, which I really enjoyed seeing the connection. So I have two questions. One, it's pretty straightforward. I didn't capture what the systolic blood pressure, what the measure was. Was it one point in time, or was it an average? Or multiple measures that were average at some point? But my other bigger question was, well, it's just fascinating, the relationship between the microaggressions and the particular clinical outcomes you're looking at. Has anyone shown that for other clinical outcomes? Or are you the first to show that sort of a relationship or something like this? And that particular metric, I guess.
Right. This is a first for postpartum. I mean, there haven't even been that many studies that follow blood pressure to 3 months. Most of the blood pressure monitoring studies follow for, it's again, this is sort of like going the 4th trimester and a little beyond. So no, it hasn't been done before. There is quite a bit of literature. Most of the outcomes that have more robust evidence have to do with more healthcare utilization and less sort of health outcomes themselves. That research is a little murkier, but I think there hasn't been a lot of robust studies yet, and probably the measures need a lot of work. And yes, Way to Health is really cool. We're trying to think of all kinds of things to do with it. Can we use this sort of as a way to assess your experiences, and then somehow, so yeah, but it's really a great platform.
Hey, great talk, thank you. So I have a question. So it's becoming increasingly common for sort of like hospital visits to include like a screening for social needs, and then an attempt to refer patients out like social service agencies. And we've been looking at sort of like disparities in availability and the extent to which agencies can get overwhelmed if we really did follow through on this plan. Are you able to, is your Apple study able to get data on any of the social determinants screening that probably has been done? And any data on like attempts to refer to agencies to address social needs?
Yeah, that's interesting. That's a great point. I know in the obstetrics literature, the actual screening that takes place is very, less than we would desire. And then of course there's the issues with follow-up. We wouldn't in the quantitative data, I don't think so. But maybe there would be interesting to know if there was some sort of measure the robustness of the social safety, like if there's within New York City, if there's a difference in the robustness of the safety net basically, and weight to access it or ability to access it, that you could look at an ecological level. So that's really interesting. Certainly in the qualitative data, that's something we should look at. In the doula studies that I'm a co-investigator on, that's certainly something that a community-based doula assists with, trying to make that warm handoff to the services.
But it's supposed to be added into all standard interactions in a lot of the hospitals now, right? They're trying to figure out how to put that into the Columbia medical record and what it means to make it go out. It's kind of unclear how well that works, or even if it's the capacity to actually catch all of those referrals to do something positive to help people who haven't referred yet. I think it's a big area of possible research for social determinants.
Yes, definitely.
So thank you for that really great talk. My question actually has to do with the expansion of this kind of work to other really important postpartum outcomes, particularly postpartum mental health outcomes, which are routinely screened for at least at the 1 month postpartum visit, but probably not afterwards. And, can be obtained, from possibly from administrative data. So are there any plans to move in that direction?
Yeah, it's a great question. Well, in the VIBE study, we did administer the EPDS postpartum, so we will be able to look at that as another outcome. And actually, the intersection between that and cardiometabolic health is also interesting because we know there's strong associations. But in terms of in the administrative data, well, I will say that the New York City birth certificate has this depression symptomatology question that isn't validated. So the health department doesn't advise you use it, but it's associated with everything in the data always. So that's sort of interesting. It's not validated, but that's readily available. So for example, in that prediction modeling, it always pops up as a predictor of the postpartum outcomes, even though it's never been validated or anything. So I'm not sure about, I know in our health system, we can get the EPDS measures. I'm not sure about the population level. That'd be interesting to look at. Certainly in the study looking at Medicaid data, which is the POEM study, and we're gonna have Medicaid data. So we're gonna be able to have, better, one of our outcomes is gonna be to look at people who ended up ever having any mental health care who had diagnosis. Oh, this maybe a question in the chat. Should I get? Yeah. Dr. Laura Carina, thank you for your talk. Will you be looking at workforce issues? How does that differ by care delivered by midwives, primary care clinicians, including family physicians and OBGYN? I know this is not the focus of your research, but do you have some thoughts about the structure of healthcare system for women and their children? Great question. So yeah, I do think, because of I think especially the work with the doula programs that I evaluate, I do think that, there's a lot of, there's great news that there's in the legislature, they're proposing the biggest Medicaid reimbursement for doulas in the US. And we think it's got the momentum to pass. So that's really exciting. So doulas can be a bigger part of the system now that they can be properly reimbursed. So I do think there's a lot of promise there, and I'm very excited about that. I do feel a little bit of hesitation that I feel like it's being proposed as sort of like doulas are the panacea for everything having to do with social screening for material, it's like the doula can do everything, which one person cannot. So and a lot of it isn't yet evidence-based, although I think that is definitely a great direction to invest in. So I guess I would say that I'm very hopeful now with the new Medicaid policy reimbursement that looks like it's around the corner, that it can be a good part of the solution, but it's not the only solution.
Just thank you for your response. I'll just weigh in. The doulas are not equivalent to midwives. So I think knowing the distinction between doulas who are supportive of birthing individuals and midwives who actually, and especially Black midwives who played an essential role in the delivery of care, should not be confused or conflated, and that it might help us to look at the experience of other countries outside of the United States that have, utilized midwives as part of the system of care for women, with obstetrician and gynecologists having the most complex cases. So that was my question. And again, I know that the vice president's meeting at the White House emphasized doulas and implicit bias. But I'm trying to go upstream to the systems of care that attend to women or birthing individuals and their children, and how we might reform that in fundamental ways.
Yeah, absolutely. I couldn't agree more. And sorry that I missed the focus on midwives, but absolutely, that's an area New York State in particular needs to bring greater access to midwife care. And it would be interesting, we have a mixture of midwives and obstetricians at at all of the hospitals in the VIBE study. But it would be interesting to sort of, I don't know if our sample size is enough, but it would be interesting to try to look at differences. So maybe we could do it in just a peek, even if the sample size isn't enough. Thank you.
Thank you.
Yeah.
Okay, so there's one more question, if it's quick, from Lahali. What is the implication of the microaggression study for intervention programs?
Yeah, great question. So of course, obviously, first and foremost, we want upstream interventions. We want them not to happen. But I will mention that at this IMPROVE workshop, the NIH workshop where I presented these findings a few weeks ago, there was some interesting data. People were presenting how different interventions, one was actually, I believe, targeting food insecurity, seemed to, when they looked at the lens of, they looked at interaction by whether or not people had experienced healthcare discrimination, self-reported, and it seemed like those who got the extra support benefited most if they were those who were sort of having bad experiences with the system. So I guess it sort of makes sense. So I thought that was an interesting way to look at it, that some of the interventions, yes, they should be targeting it from happening, but also it can be a flag that this person is not having good experiences with the system and might need the extra support to be able to have the best health outcomes. And so then in terms of upstream solutions, that's $1 million question, and definitely something I've been thinking about. One tiny, it would only be a drop in this ocean of the issue, but I did submit a proposal to do a training program where we use sort of a more interactive platform, is with association, collaboration with patient experience and diversity and inclusion chair at Sinai, Dr. Tony Stern, where we're to look at during training of clerkships to how to have kind of an interactive platform where the medical students can actually in the OB/GYN clerkship, when they're witnessing different interactions, have a space to then reflect on it. Like, how could you disrupt this? What might be interpreted as bias, to sort of start to more instead of just sitting and listening to a lecture on implicit bias, to sort of interactively, while they're doing active learning in their clerkship, think about these styles. So that's under review right now at NIH. But again, I know that's just a drop in the ocean of the issue. But I agree, it's an important question to have answered.
I want to thank you again for this wonderful talk. And I hope you enjoy your afternoon here. Okay, thank you, everybody.
That's so great. We're gonna talk soon, so.
Okay, great. Yeah, I'll see you
Really
this
good.
afternoon.
Absolutely,
Glad you enjoyed it.
absolutely. Okay, talk soon.
Good.